Okay, we're now going to dive into our panelists. So great group we have here. And I'm going to introduce the three people that have not yet been introduced. Lee Goldsmith, who many of you know, a graduate of NYU School of Medicine and NYU School of Law, past president of the American College of Legal Medicine and New Jersey Association of Justice. He's of counsel to Barroso, Bromberg, and Newman, certified trial attorney. And we also have with us James Mulshine, a professor at Rush University, where he has served as associate provost and vice president for research, while also acting as head of the Rush Cancer Center for 2 years, and as well dean of the Graduate College for 6 years. Prior to joining Rush in 2005, Dr. Mulshine was at the National Cancer Institute for 25 years, where he was on the research faculty, internationally recognized as an expert on lung cancer. He's a thoracic medical oncologist with a long time interest in lung cancer. And last but certainly not least, Bruce Pyenson is a healthcare actuary who has consulted to virtually every sector in healthcare and served as a commissioner on the Federal Medicare Payment Advisory Commission. His recent work has included developing a quantitative alternative to quality adjusted life years and exploring the use of public service utilities to run healthcare enterprises. So without further ado, let's begin our panel from closest to me, Lee, and ending with Dr. Koong. So please jump in, Lee.
Thank you very much. Let me start from a completely different point of view. I have both degrees in law and medicine. I practice law only in the field of medicine. So I sympathize with Dr. Rovsky when he mentions he's got to run a department, he's got to take care of patients, he's got to get the information out, and he's got a budget to run under. I can sympathize with Dr. Aguayo when he mentions his running the VA and the fact that he is unable to screen the number of patients he needs to screen and won't be able to do for a certain period of time. I also look at what Dr. Nagavi and Dr. Mulshine have mentioned about the comprehensive information that will come out of the CTs. Tremendous amount of information. Who's going to handle it? How is it going to be handled? And then I switch and I turn on my lawyer's hat. I don't give a darn. I represent the patient who should be screened, who needs to be screened, and is not being screened. I represent the patient whose information is being left in the chart and not being handled. And how are we going to get the patients who need to be screened, screened? So on one side, you say, okay, there's litigation. None of us wants to see litigation. None of us wants to see our colleagues sued. I have been sued as a lawyer. It goes with the turf. But the patient is the one we are responsible for, both as physicians and as an attorney. And as such, wearing my legal hat, that patient who should be screened should be screened. That patient who fits into the criteria of screening should be screened. Why isn't that patient's name coming up? Why isn't that patient being screened? So, too few of those patients even know that they have a right to litigate. Too few of them are ever getting into a lawyer's office. And when we see litigation, it's being handled and being passed on. It's a cost of doing business. End result is we have a piece of litigation, you have a lawsuit, a person gets money, and the other 10, 15, 20 people or 30 people or 100 people who should be screened aren't being screened. How are we going to get them screened? One of the things that we've been discussing over the period of time is how do we get the screening process stimulated? How do we get a Dr. Aguayo allowed to get the screening patients screened? Where is that money going to come from? How are they going to get it? Now, I was involved in the tobacco litigation in 1966, which ended up in the tobacco settlement of 1998. That has not created screening. In fact, all it's done basically is immunize the tobacco industry from litigation. I've been involved in the opioid litigation. Why did we even get into that situation where that many people had been affected through the opioids? Okay. What I've been considering at this point in time over the last few months is how can we effectuate and increase the amount of people to be screened? I've been talking to pulmonologists and I've been talking about the electronic health record. Recently, as an aside, I was in a podiatrist's office and the podiatrist before I left me a screening tube. Am I depressed? She says it's mandatory that everybody who comes into the office fill out this form and list whether or not I have any of the criteria of depression. Filled out the form, mandatory. Why isn't screening mandatory? Why doesn't it come through the electronic health record that you must be given the information and sent for screening? It does not occur. In talking to pulmonologists, there are many gaps in that record that don't require screening to occur. So even though Dr. Aguayo can tell me every single one of his people within the VA that should be screened, they're not going to be screened for another 7 years, according to him. Why not? Where are our failures and how can we stimulate that screening to be done? Unfortunately, it's going to have to be litigation, because the medical community has not been able to get it accomplished. For all the years that I've worked with Claudia and David, fantastic period of time, how much they've worked so hard to get screening accomplished, it has not been done. And it's not their fault, and it's not you fault who are sitting out here who want screening to be done, but the end game is that it's not being done. So unfortunately, we have to go to litigation, I believe, to get it done. And I think we have to change the electronic health record so that it stimulates every person to be screened, whether the system can afford it or not. And very simply, I'm not here to give you good news. We need the litigation to simulate the process. And the profit motive has got to be taken out of the incentive not to be screened. And that's my couple of words.
Good point. Now, before you jump in here, I will just simply say that our speakers were able to suggest questions, and one of Jim's questions, I think, is very closely linked to the comments that Lee just made. And the question is, what are the implications of having a single reimbursed annual test that can detect the pre-symptomatic phase of lung cancer, heart disease, and emphysema, especially if the clinical course of these three diseases can be monitored longitudinally? Jim.
I think it's it's an enormous opportunity, and I'm going to back up just a touch because what we're here doing is trying to create a cross-rough between the importance of tobacco cessation and the end game, which, you know, Chris has told us is the relevant in the most lethal cause of death across the world right now, which people don't understand. And screening, where we can now see the pre-symptomatic phase of these diseases. And I think this, to get a precedent for this, I think we go back to HIV. And I'm doing this because Cheryl is a long-standing champion in this HIV field as well before she came to tobacco. You needed, it's an incredibly important threat to our society, and you needed a multi-channel response to it. It wasn't this or that. You had to do more than, you had to do prevention, you had to do education, you had to do communications. And I think we're obviously in the same setting with lung cancer and tobacco and screening right now. Now, I think our society met the challenge of HIV in an unbelievably successful way. That was going to be the next plague, and it was going to roll through the world, and it was going to do this, that. It didn't, because as a society across the world, we united and developed strategies and research and communications, and it didn't happen. And it's still a very important disease and still afflicts people, but not the way we thought it was going to. Okay, so quickly, The end game is phenomenal. It's important and we should fully endorse it. Screening is important and we should endorse it. But the reason why we pull it together is because the decision to smoke comes in childhood. That is oppression. That is oppression. And the decision to smoke, we're going to try to intercept that completely. Absolutely agree. But many people did decide to smoke and have a lifetime of it. And because of that, are going to forfeit on average 10 to 15 years of life. We, through screening, want them to get their productive life back. And I think that's the intersection that we can really build on and say, this is an inclusive, humane approach.
I would just add, great points, Jim. I would just add one thing. In a sense, the comprehensive screening is an end game. It's an ongoing end game. And I mean, it's a different concept. It's instead of being at the front end where the assembly line is coming through, it's at the back end where the damage is already beginning from, for multiple diseases, for many of which tobacco is the core bad guy, shall we say. Yes. Now hold on. We're now moving on and we'll have a question from Bruce. Bruce, will it be important to measure the short-term outcomes of implementing the end game? And how might the outcomes be measured?
I think the progress, the cases in the cities where there's been end game implemented are wonderful examples, and we need to measure their outcomes because we're in a marathon, we're in a fight, and the tobacco industry is not going to sit back and let all this happen. So the outcomes, the successes, the impact on disease, on hospitalizations, emergency room, on exacerbations has to be measured, and we need that for two purposes: one, to beat back the tobacco industry, and the other is to accelerate adoption by other geographical areas. So I think one of the ways, as we think about that, one of the ways to do it is to set up several measures that we know will be affected and to start collecting the data as soon as possible on those. For example, cases of pneumonia among the generation, the first cohort that is tobacco-free, or absences from school, or any number of other things, but to set up several measures because they're not all going to work out just because statistically they don't, and it's often hard to collect data on everything you want. So I think that's a something to think about from a population health standpoint.
That's an excellent point. And I would just also add not just the age band, but the end game period in places where it has been implemented, like Beverly Hills. In a sense, if you think about it, Beverly Hills went from being stars for sale to smoke in our movies to banning the sale of tobacco altogether in Beverly Hills. And the former mayor of Beverly Hills is on the board of the organization that Chris is the policy lead on. And, he was really very instrumental in making that happen. And it's a wonderful thing. And it would be interesting to see what's happening to young people there now and what level of smoking they're reporting after the sales ban versus before. Hank, please.
Thank you. So the way Dr. Lee's responding to Dr. Lee's comment about litigation as a motivation for us to go forward, as a practicing physician, surgeon, I would certainly hope that does not happen because it's a painful process. As a interim measure and drawing upon the complexity of tobacco control topic, as well as the complexity of screening for lung cancers and comprehensive health screening. I think the senior people here, you are the experts, and you have spent your lifetime and continue to spend your lifetime championing to collect the data. But I think what's sorely missing in both tobacco control and the comprehensive health screening is that simplified lay language articulation that needs to go out to the public, so that the public, members of the public will then articulate, the media will simplify it in a manner that gets the public to have a ground-up approach. I think the bridge to this will be really engaging the young people in the audience, because working with them for the past 10 years, I think they have a remarkable way of simplifying what we teach within 5 minutes, 2 minutes through a TikTok video. You see? And I think once you have them coming on board, they become our voices, they become our faces to deliver this across to our patients. And they are the ones who then ask their physicians, can I go for my screening? Can I contribute to promoting and preventing my kids from being addicted to nicotine? And I support the tobacco-free generation public policy so that it protects future generation and it's not prohibitive. So I think that's the common factor.
Very, very good.
And one more thing, with regard to the outcome measures, I think Stanford Social Innovation has a publication to say that when you're trying to prevent something, it is hard to measure the end outcome of it because you have prevented it, you have stopped it. But I think what the key message that I got from the paper was that we need to pick up surrogate measures. How many global health institutes have now internalized a tobacco-free generation endgame workshop into their curriculum, whereby medical students now can champion this and promote this across the world. So I think those are the surrogate measures that can be measured and published in order to garner greater global support. Thank you.
Very good point. We have Dr. Granis interested in asking a question. If someone can get him a mic.
Got one.
Oh, you've got a mic?
Yeah.
Okay, great. Go.
I just wanted to express my respect for Ash and for the work that you're doing. I have one question. You didn't get to look at this end game strategy because your talk was a little bit truncated. But if we have a serial killer in our society who's torturing and killing people serially, we don't tax them higher. We don't make them wear a shirt that says I'm a serial killer. We don't warn children not to go near you. We arrest you and we take you to court and we try to get a conviction for, in this case, premeditated murder. So Ash has adopted that strategy in the past. Can you update on where that's ever gone anywhere?
Yes, so this is a key part of Endgame, and it's going nuclear, because in a jurisdiction where a judge declares that it is murder to sell tobacco products, obviously the next day you cannot sell tobacco products in that jurisdiction. We have not yet been able to find that prosecutor. We've talked to several attorneys general's offices and some DAs. It's a big ask. No one's ever tried it before. The tobacco industry's pockets are endless. And they will fight it back, obviously, because we're going after not just the companies, but their executives, right? So they're going to go to prison if we succeed. So we're looking for that prosecutor that wants to be attorney general or a governor someday and make a big splash, right? Be the first person to convict the tobacco industry. So if you know prosecutors that might be like that, please let me know. We have a brief that we can share, and we do believe this is possible. And it's not just us saying that. We did bring a group of law school professors to ASH a few years ago, sat them down for 2 days and told them, tell us where we're wrong. And when they left, they said, you could probably do this. Just need the prosecutor.
And I would just add to Chris's point, because I was in the meeting when we talked to the Attorney General's office in New York State. And in fact, it was acknowledged in that office that there was absolutely a pathway for CMS New York to bring such a case. And they elected not to. And at least one person in that room, I think, was ashamed that they elected not to. And if it had been up to him, he would have moved forward. So Lee, in your spare time, they know they can do this.
Well, I'm going to question that and refer back to the Depression area where we banned alcohol use. And all it did was drive it underground. So the Attorney Generals, I think, would be very, very cautious about saying we can ban tobacco because of the underground industry that would create. I think that education, working with everybody, trying to persuade them not to and educating them not to get into tobacco is the way to go. And also to provide the health care necessary so that the diagnoses are made early and the treatment can be done. The only way to really put the tobacco industry out of business is to make them responsible for all the costs that occur. And with the 1998 global settlement, I don't know if that is possible anymore in this country because of that. So we have to look to alternatives. I don't want to see litigation, even though that's how I've made my living these entire years, because it's not the way to go. It's not the way to protect you guys sitting out there. But at the same time, how are we going to get everybody screened who should be screened? If the VA can't do it with its system and it's got such a deadlock, well, how do we stimulate? And how, at this point in time, the article that you provided me, okay, ran into the question, why isn't screening being done? And I think screening is not being done because it's not mandatory. It's not being forced on the physicians to get it done, even though we have the expenses and the equipment to get it done. So the question is, why isn't screening, rather than the 15 or 20% that is being done, why aren't 100% of the individuals who should be screened every year? I don't have an answer to that question.
Jim wants to jump in here, and I will say that I stand corrected. It is being done in China. So someone came up to me after the panel who was actually on the panel and pointed that out. Jim.
If we're going to drive this underground, if we ban tobacco completely, there'll be an alternative. We call it vaping. That's one thing. Second thing is, I'm delighted there's a number of younger people here. I'm very old young, but one of the people that we got to know is the person who litigated Philip Morris successfully in the Department of Justice. And the tobacco papers came out of it, and it was transformational in our ability to understand the working of the tobacco industry and have objective proof and master settlement agreement, all kinds of things happened as a consequence. The woman who did this was a very capable lawyer who had previously done 31, I believe, successful cases for the Department of Justice without a defeat. She was appointed during the Clinton administration.
You're talking about Sharon Eubanks.
Sharon Eubanks. This is one of the most courageous people in the history of public health, because she did do that trial and she wrote a book about it with Stanton Glantz.
Bad acts.
Bad acts. Try to get it, because it is so instructive how the tobacco industry tried to crush her in 26 different ways. And the government, unfortunately, as it transitioned to a different administration, the person in charge of being her supervisor was the previous vice president of Philip Morris.
JR.
RJR, okay, Reynolds. It is very important not to lose what a challenge you're addressing, to understand it and develop successful strategies. We have momentum. We have examples of other countries. When Korea went after smoking 20 years ago, their rate of tobacco cessation went from here to there within 3 years. I mean, it can be done.
those are great observations and I'll just, yeah, okay, sure, please go. Yeah.
Very quick points. First, that DOJ case actually started criminal, and they decided to go civil. So they were definitely looking at it that way. And all 23 jurisdictions in the United States that have passed endgame laws have included commercial nicotine products. It's everything other than medicinal products. So they won't be able to move on to the next thing.
The only thing I was going to add in that same RICO case where I was a fact witness, which was not a fun experience for me or any other fact witness in that case. The moment when they came to blows, literally in the White House, that's written up in the book Bad Acts, was over the mandate that the ask for the settlement that the Justice Department was requesting, that it be so sharply dropped. It was extraordinary. I mean, when I say it was like 97% reduction in the request, and part of that request would have endowed what's now the Truth Initiative in perpetuity at an extremely high level with a $9 billion endowment. So, I mean, a lot was hanging in the balance when the person intervened in the Bush 2 White House to stop that. Yes.
So how I see, if you don't mind, I stand. Yes. So how I see TFG comes in to mitigate against all the legal challenges is the fact that young people like you all will create the social media material and tell the public that a birth year-based policy is so rational, so logical and simple. Why would anybody go against it? You see, you start wondering what are the external influences, the under-table influences that's going on. And you start undermining perhaps maybe if it's so logical for people like us who are young, why is it so difficult for a senior person? Perhaps something is going on, but you keep persevering, persisting in order to champion for the health of your future generation. So I think that's how I see TFG in defending against higher level decisions that you have no control over, but you make a big difference to your generation because your voices will be stronger than people like me who's much older.
I think that's a good point. I'd like to hear what the panel thinks might be the platform and positioning that the tobacco industry could use to object to tobacco-free generation.
It's very clear. They're going to say it's restriction of freedom. And I think that's a pretty good bet amongst other. And I think to vaccinate against that, I think that what you're talking about with Endgame and what we're talking about from the information on all these different consequences of smoking on the scan is we're talking about empowering individuals to make informed health choice. This is about individual empowerment. It's not restricting freedom. It's empowering. And I think you have to do some offense and not just play defense, but to allow people to understand the consequences of their world, smoking, atmospheric pollution, whatever, and to make informed, rational choices around that. That's empowerment. And that's the opposite of stigma. You are powerful. You're not a victim.
And
I'm going to take this two different ways. We have the generation to be that is not smoking. And what are we going to do for them to make sure that they stay that way? And I agree tremendously with everybody what's been said. We've got to educate them so they don't smoke. The other question, which I'm trying to present, is what do we do with those who are now vulnerable? How do we get them screened? How do we get them treated? And how do we get them through the process so that the longevity increases? So that's also part of the problem. And that's what I'm trying to face.
What do people think about JACO requirements? I mean, it's one of the opt-in preventive services that hospitals can say they want to be measured by. Why couldn't they be required to be measured by, whether they did or did not fail to screen?
I think I have a distinguished expert to my right about incentives along exactly that line.
The,
Okay, you'll go. Go ahead.
the vehicle in the US is the Medicare Advantage star metrics. There are billions of dollars that get moved to the Medicare Advantage insurance companies each year based on their performance of quality metrics such as mammography rates or immunization. There's a series of about 35 different metrics, and establishing a screening metric that's simple to use, such as the portion of incident lung cancers that are subsequent to screening, would create a huge incentive for the insurance industry to get it done. And they'll figure out how to get it done with their networks of physicians.
Fang, you wanted to make a comment?
On the getting people to be motivated enough to screen, my personal take is that by getting the community engaged and young people are aware, they talk to their family members and they encourage them to screen. I think that's more powerful than someone telling them from outside that they need to be screened. I think a family member, a loved one telling another to come in for screening, I think that will contribute a lot. Another item I want to address is what Dr. Lee Goldsmith mentioned about how the biggest challenge is the tobacco industry continue to say that this is infringement of personal rights. I may not have elaborated that enough in my rushing through of the presentation. But I think the key is that to start to realize that when you have a tobacco-free generation law based on a certain birth year onwards, for example, I think I'm guessing you all are born in, let's just say 2010. Yeah. The law affects them, but it doesn't affect the rest of us who are born before 2010. If their cohort starts to say that tobacco-free generation is not infringing on the rights, and the entire cohort of the entire city claims to be so, people who are born before have no right to say that it is infringing on their rights, because they are the people who are affected, and they are the people who say this is protective. You see? So these are the narratives that we have to overcome every time we run workshops for tobacco-free generation. I think these are the details and the narrative that need to carefully nurture so that the public start to realize that tobacco-free generation is not against all smokers, but we are focusing on the future generation. Thank you.
Questions from the audience?
Yeah, thank you very much. I'm speaking for, I guess, the younger generation. How can we reconcile tobacco endgame and movement like cannabis legalization? And I think it's not so easy.
So how we do it at our workshop is to start letting the young ones know the fundamental benefits of tobacco-free generation over the current policies, using nicotine addiction as the first example. From our experience, having the young people having understood that fundamental concept, they can do their own projection to start saying, hey, we should be championing against cannabis. You see, it's a natural thing because these young people, all of us have gone through the same idealistic phase of our life where we want to make a difference to the world at 16, 17 years old. And if you can see cannabis as an issue, they will champion it on their own. And you think about it, by instilling the advocacy skill into the young people, they can use the tobacco-free generation as a tool to learn, and they can champion against any other social injustice there is, because this is just a tool that they learn, a skill that can be extended to the rest. Thank you.
Thank you. And we're going to wrap up, but I do want to just interject one observation here on the comment that was just made. The tobacco-free generation means that entire cohort throughout life cannot legally smoke within the country. In most jurisdictions, young people cannot purchase tobacco and they cannot purchase marijuana. Of course, they do through other mechanisms and they get access through other mechanisms. So it's there's a little nuance there. And then there is a very different profile in terms of morbidity and mortality. I won't go into the details, but I will say the search for mortality is largely a search in vain. And that does, give it a different flavor in terms of whether it will get the attention for a marijuana-free generation. And on that note, we're done. Thank you so much.